first speaker will be Professor Dr. Gregory W. Barsness. This is very interesting because both of our speakers today are cardiologists and interventional cardiologists, and they are going to talk about EECP. The first session, the first topic will be EECP from physiology to clinical practice by Professor Gregory Barsness. He is a cardiologist and interventional cardiologist. He is the director of Cardiac Division of Cardiovascular Disease, Department of Internal Medicine, Mayo Clinic, Rochester, Minnesota, USA. He is also director of EECP Laboratory Divisions of Cardiovascular Disease. He is also teaching as a professor and also as consultant. He's also consultant in the Division of Cardiovascular Disease. Please welcome Professor Gregory Barsness.
Thank you very much. Salman, thank you very much. I would like to again thank the organizers of the meeting, chairman, and many new friends and colleagues for this gracious hospitality and wonderful opportunity to visit Indonesia, which I have been here for the first time now and have found it to be just a very warm and fantastic place with very enthusiastic and capable and very educated, knowledgeable cardiologists. So thank you so much for this opportunity. And by the way, congratulations and happy Independence Day. Merdeka! Today I'm going to talk about EECP and specifically the physiology behind the application of EECP. What we know about the mechanism, what we know about the effects, and how that might lead us into the future. So, to start with, in the United States, EECP is used primarily for patients with refractory or unremitting chest pain. This is a very large group of patients. There are 16.5 million people in the United States who have coronary disease, and many of those, perhaps most of those, have persistent chest pain, despite having undergone revascularization, being on medical therapy, exercising, and doing the right thing. It's actually estimated that about 1 to 2.5 million people in the United States have coronary disease that's not amenable to further revascularization. So there's a very large population of people who are in need of additional therapies beyond the standard revascularization and medical approaches that we've used for years. The numbers of patients with this refractory chest pain is likely increasing over the years with the failure of these palliative therapies. And remember that coronary disease is a chronic recalcitrant condition, so it recurs, and despite revascularization with PCI or bypass surgery, symptoms do recur or persist after those therapies. So these therapies are only palliative, they're not curative. And the prevalence of refractory angina increases with time, especially as the population ages and as refractoriness and as risk factors increase. In our data set of patients with refractory angina, and these are patients who were seen by me and some of my colleagues from interventional cardiology and also seen by bypass surgeons who were felt to be not candidates for any of those procedures and were on optimal medical therapy. We followed their progress over the years, and actually mortality or death rates following visits to the doctor increase fairly dramatically over time. So there's a fairly substantial mortality risk among these patients. However, the cardiac-specific mortality is only half of the overall mortality. This is a very important feature of coronary disease. So whether you're looking at stable chronic angina, refractory angina, or even outcome following acute coronary syndromes, although the mortality is relatively high in this population, only half of that mortality is cardiac-specific mortality. So our ability to impact that mortality is limited. It's very important to understand. So Our goal for these patients is to help them do their very best and help them to do better over time, but really we're talking about symptom control in this population of patients. Symptom control is very important. It's a less understood component of these patients because we even know that after full revascularization with bypass surgery or PCI, only 30% of patients feel well enough to go back to work after revascularization. So, or excuse me, 30% never return to work. So a third of patients don't or feel too poorly to go back to work after revascularization. And 15 to 20% of patients rate their health as poor even after bypass or PCI. Why is this? Why do people feel poorly and what can we do about it? I'd like to shift gears a little bit and talk about endothelial function and the role that that might play in all of this. I'm an interventional cardiologist and I do a large volume of CTO work, total occlusion work, and this is just a patient that I saw within the last year, and I performed CTO PCI. So this was a patient who was highly symptomatic. I was able to open up his LAD artery and get a pretty good result. But you see the LAD distal to the stent that was placed looks very diseased. It does not look like a healthy vessel. It's unclear how that would ever benefit the patient in the symptoms. He came back 7 months later for an unrelated problem and had repeat coronary angiography. And you see the LAD is now a big vessel. So the difference between the acute result and this vessel is that the LAD is now a healthy looking vessel. Nothing else was done. PCI was the same, no more stents were put in, but the vessel looks different. And that has to do with the shear stress imparted on this vessel. So before the CTO intervention, there were no shear forces in the vessel, so it was small and diseased looking. But after 7 months of normal flow through the vessel, the blood vessel perked up and it looked normal. So the shear stress in this case was protective but also vasodilatory. So the shear forces help heal the blood vessel. And how do you do that? Endothelium is central to that. And many of you know this. In fact, probably most know this. But normal endothelial function is a balance between the good factors of nitric oxide and prostaglandins and the bad factors, endothelin and angiotensin and others. This normal endothelial balance promotes vasodilatation and an atheroprotective atmosphere. When the endothelial function is out of balance, when there's dysfunction, there's relatively more of the bad factors of angiotensin and endothelin, relatively less of the good factors of nitric oxide and the effects of those. And what you end up with is vasoconstriction, atherogenesis, and you actually have decreased endothelial repair. So poor endothelial function leads to poor endothelial health and poor endothelial repair. So actually you need to do something active to promote good health. Endothelial function, as you know, is one of the first things that happens when you develop atherosclerosis. So endothelial function is or endothelial dysfunction is very prevalent. Coronary endothelial dysfunction is also associated with risk factors. So the more risk factors you have, as shown in this study, the worse your endothelial function. So there's a direct correlation between risk factors and endothelial dysfunction. There's a direct correlation between ischemia and endothelial dysfunction. So here in this trial, looking at invasive coronary endothelial function, you see that people with ischemia, shown in red, have abnormal endothelial provocation to acetylcholine, abnormal endothelial function. Whereas if you can't show ischemia in this patient with chest pain, their endothelial function is normal. So not much you can impact there. Finally, abnormal endothelial function is associated with poor outcome. So patients who have established endothelial dysfunction have worse long-term outcome, more evidence of MACE and myocardial infarction and death in follow-up. So that brings us to EECP and the effects of EECP. Let's see if it loads. EECP involves a non-invasive outpatient therapy whereby 3 big sets of blood pressure cuffs are applied to the lower extremities. Let's keep going. And these these blood pressure cuffs, or these big pneumatic cuffs, inflate and deflate with the heartbeat in order to promote diastolic afterload, diastolic augmentation, systolic afterload reduction, and actually improvement of the coronary circuit. I'll just go on to the next slide. I think we're frozen a little bit. So the it's going to be very pretty when it actually works. This session of EECP is actually a 35-week course of session, 35 days over 7 weeks, excuse me, of an hour apiece. So the patient lays on a table with these pneumatic cuffs, and perhaps for those of you who've seen, these cuffs inflate in a sequential manner, kind of milking blood up centrally from the lower extremities into the body, and that has been shown to improve diastolic blood flow. If you can just move to the next slide. In a variety of vascular territories, including cerebrovascular territories, renal territories, and coronary territories. This hemodynamic effect is well shown. So what you end up with is you can get, as I said, improved diastolic flow in a variety of vascular beds. You get improvement in cardiac and in afterload reduction. You get improved diastolic augmentation into the coronaries. You get improved preload so that the cardiac output actually increases by up to 20%. Oh, there it goes. Here. Very good support. Thank you. So that was it. And as you can see, ECP increases diastolic intracoronary pressure by 2 times and Doppler flow by 78%. It's a very robust hemodynamic means of getting non-invasive, but hemodynamic support throughout the vasculature. Because these shear forces are active, we chose to evaluate a couple of potential mechanisms of clinical effect. This has been shown to improve angina scores and other features which Dr. Lowe will comment on. But we looked at endothelial function and its role as sort of passive exercise to see what benefit there might be. It had been shown that shear forces can be measured directly in an animal model and increased during the course of EECP therapy. And in the intact human, this increased shear force is associated with a dose-dependent increase and improvement in nitric oxide levels and an associated decrease, again, with the course of therapy, a dose-dependent, dose-related reduction in endothelin. So that the nitric oxide to endothelin ratio, that important ratio that determines endothelial function and endothelial health, is favorably modulated through EECP in intact humans. We looked at what the systemic effect of that might be using peripheral arterial tonometry. That is a device that has been shown to correlate with coronary endothelial function and is analogous to forearm-mediated brachial reactivity. And we looked at our patients undergoing ECP therapy, measured their endothelial function both before and after treatment on days 1, day 17, and day 35, the last day of treatment. And what we found, and what you can see on the slide, is that at baseline, endothelial function was markedly deranged. The normal number is closer to 1.5 to 2, and you can see that it was deranged. But after each day, including after the first day, there was an improvement in their measured endothelial function with the course of therapy. However, on each day, including the last day of therapy, the baseline, the resting endothelial function measurement was not changed and was in an abnormal range. However, and you can see that this number of 1.2 is the ratio at which coronary endothelial function starts. So each day it started with a poor marker of endothelial function, but with each therapy, their endothelial function improved to a suitable or favorable physiologic number. When we did a month follow-up, so this is a resting endothelial function at 1 month, we found a statistically significant and clinically meaningful improvement in their endothelial function. And this was associated with improvement in their CCS class. So in patients who had CCS class improvement with therapy, and that was most patients, their response in our studies is about 90%. So 90% of the patients have response, and in those patients, their coronary endothelial function measurement improved with the course of therapy, compared to patients who did not experience, a small number of patients who did not experience a benefit, they did not have a change in their endothelial function. The same thing happened with the DAISY score, the Duke Activity Status Index, a functional class measurement. And those patients who improved had improved endothelial function, suggesting that this is a mechanism of benefit for these patients. It had also been shown that the number of endothelial precursor cells circulating in the body are correlated with endothelial function and good outcome. And so we measured coronary endothelial precursor cells in our patients undergoing ECP as well in a separate study. It had previously been shown by our group that in patients who were normal compared to patients with established coronary endothelial dysfunction, what's normally termed EPC cells or endothelial precursor cells did not change much between coronary endothelial dysfunction and normal patients. However, hematopoietic precursor cells, or the stem cells, actually were different between coronary endothelial dysfunction patients and normal patients. And so when we looked at our patients undergoing ECP, you see at baseline all of the markers were markedly depressed. However, again, in a dose-dependent manner, the hematopoietic precursor cells were modulated in a favorable direction with EECP, suggesting again that this mechanism of healing of the endothelium was perhaps a modulator of the clinical effect. Looking at a systemic basis, the effect of this improved endothelial function is reflected in myocardial energetics. And so in this study by Nichols and colleagues, they looked at the peripheral tonometry and measured the aortic capacitance, and were able to measure reflected waves from the periphery. So when the heart beats, there's a wave that goes down, it's reflected back at the heart. And this can become maladaptive over time because the reflected wave comes during systole, and so the heart has to push really hard against this reflected wave, wasting a lot of energy. And what they found was that EECP was associated with a favorable change in this reflected wave. Improved capacitance, a weaker reflected wave that came at a more opportune time in the cardiac cycle to decrease the wasted energy of the heart pumping against this reflected wave. So ECP has a hemodynamic effect that's durable even after the course of therapy. And this is reflected specifically in diastolic function with improved filling rates and time to peak filling of the LVs consistent with improved diastolic function, which of course is what is a major means of impacting our patients with coronary disease in general. Finally, there was a very comprehensive study by Gregory and colleagues that looked at a variety of markers to really consolidate. This was a randomized study looking at a variety of endpoints of patients undergoing EECP or undergoing a sham trial. And what you saw is that there was improvement in nitric oxide, endothelin was downregulated like we saw before. There was an improvement in the nitric oxide to endothelin ratio. Flow-mediated dilatation was improved. Cellular adhesion molecules, and inflammatory cytokines were all modulated in a favorable direction, and symptom status improved. again, suggesting that all of this fits together with endothelial dysfunction improvement as a central mechanism of effect. Just like exercise improves your endothelial function, ECP has a similar sort of mechanistic benefit. And finally, although I've shown that endothelial dysfunction is associated with poor outcome, what we really want to show our patients is that improvement of their endothelial function is associated with good outcome. And that's what this slide points to. So in this study of patients who were not EECP treated, but who had therapies to improve their general health, so risk factor modification, optimized medical regimen, better exercise. In those patients in this study who had improved endothelial function, their adverse cardiac events were decreased over time, whereas patients who did not have improvement in their endothelial function suffered worse long-term outcome. So endothelial function, improved endothelial function, actually can be associated with better outcomes, suggesting that means to improve endothelial function may promote better health in the long term for the patients. The bottom line is that optimal medical therapy and risk factor modification are essential, and endothelial dysfunction is a central actor in poor outcome. EECPs provide safe, effective, and durable symptom relief with improved quality of life and vascular health. And it's a potential pathway, although unproven, and I want to point that out, it's unproven, but a potential pathway to improved prognosis via improved endothelial function, as we've shown. How do I use EECP? Well, first of all, most of the patients who come to me are looking for a second opinion. So I look over things, I make sure they're on optimal medical therapy, I make sure they're exercising if they can. I make sure that standard revascularization is applied if appropriate. So if they have options for standard PCI or bypass surgery, I certainly offer that to these patients. However, if they're not amenable to those therapies, EECP remains one of my favorite approaches. So that would be next on my list of approaches for patients who have refractory symptoms. Spinal cord stimulation and TMR are things that we don't use much anymore, but clinical investigations, including therapeutic angiogenesis and other new forms of therapy, are certainly something I employ as well. But EECP is in that realm of things that we do. And with that, thank you very much.
Thank you, Dr. Barsness. The discussion will be with the speaker. And now I would like to invite